And moderator, thanks for a very short and sharp presentation. That was excellent. Thank you. Let's move on. The next session is on health-related quality of life outcomes. Vaishali will present for her working group. Vaishali, I think it's you're up. Do we have her teed up? And as she's speaking, I think in this section, I think we've got quite a few, we're sort of in process with analysing different scales. So Vaishali is going to introduce, how they're thinking about analysing different scales. I don't know if the technical moderators can have Vaishali. Great.
Are you able to?
We are. We can't see you.
Right. I think I can't.
Don't worry about that. I think many know you.
It says the host has stopped my video.
We can see your slides, so why don't you stop?
Right, but the host has stopped my video. That's what it says. Okay.
Well, we can hear you and see your slides.
Okay,
so
and now you can see me too.
Thank you.
Okay. So good afternoon, everyone. And I would like to begin by thanking ARC, specifically Kristen, and also FDA for allowing me to present from our working group on health-related quality of life. It is a total honor and a deep privilege to present on behalf of my working group members who are listed over here. They gave me valuable opinions as well as expertise on going through the working group calls as well as developing this presentation. So the goals of the working group were first to conduct a systematic literature review and update existing conceptual framework if needed. Then the second goal is to map concepts to existing tools and measures, identifying which concepts are adequately covered by existing tools and which concepts may not be adequately covered by existing tools. The next goal is to prioritize the concepts important to measure for drug development with feedback and involvement from additional organ-specific groups, and the most importantly, from the patients. And finally, to develop a set of recommendations on use of existing instruments and potential need to create a new instrument to cover gaps in concepts between the updated conceptual model and existing instruments. We performed a very, very strategic and formal literature review, and this was conducted in PubMed on December 22nd, 2020. To assess the completeness and accuracy of the search strategy, records were cross-referenced with list of articles provided by me, the patient-reported outcomes section of the recent review article by Lin et al., and the internal quality metric list of publications. The literature review was performed with the disease name and the areas of interest, which included health-related quality of life, physical functioning, mental health, satisfaction, and research methodology. This search strategy gave us unique records of 173. Of these, 146 abstracts were screened for relevance, and 37 articles were selected for full text review. Of these, 27 articles that report on the use of patient-reported outcome measures in AL amyloidosis. This is the summary slide of literature review findings. As anticipated, unfortunately, no AL amyloidosis specific PROs have been reported in the published literature. A total of 24 different patient-reported outcome tools have been used to assess patients with AL amyloidosis. The most frequently reported PROs were generic measures of health-related quality of life, and these PROs were not developed to assess a specific disease. PROs developed to assess patients with cancer, heart failure, and hematologic conditions have all been used in AL amyloidosis. In addition to measures of overall health-related quality of life, PROs have been used to assess individual concepts of interest such as global functioning, mental health, fatigue, and pain. Evaluation of content validity and psychometric properties in patients with AL amyloidosis has only been conducted for short form 36 version 2. The content validity is defined as the survey which is appropriate and understandable to patients with AL amyloidosis. And psychometric properties is defined as the survey that yields consistent estimates of true effects and is related in a logical way to other measures and patient characteristics. And lastly, thresholds for minimal important differences and or minimal important changes specific for AL amyloidosis have not been established or estimated for any PROs. Thresholds for some of the instruments that have been already mentioned, SF36, FACT-G, EORTC-QLQC30, KCCQ12, have been estimated using general population or other disease-specific samples. Many of the PROs that have been used in patients with AL amyloidosis assess multiple dimensions of functioning and well-being, though none were developed specifically for patients with AL amyloidosis. The generic PROs that were used in published literature are listed on the left box, which are SF36, PROMIS Global Health Scale, and PROMIS 29 Profile. Cancer-specific PROs that are used in AL amyloidosis and reported in the published literature are FACT-G, EORTC-QLQC30, and NCCN Distress Thermometer. Heart failure-specific PRO that is used in patients with AL amyloidosis is KCCQ12. And the hematologic condition-specific PRO is HPRSS, which has also been used in patients with AL amyloidosis. Other PROs have been used to provide more narrow assessment of specific aspects of patients' experiences. These are single item assessments which measure functioning or disease severity at a global level and are listed on the first box. Mental health assessments, which may include assessment of depressive symptoms, anxiety, or overall mental well-being, which are listed in the middle box, and symptom-specific PROs, which have been used to assess pain, fatigue, and sleep in patients with AL amyloidosis. It is important to note that there are certain study-specific survey items which are used in certain publications as well as in certain studies in AL amyloidosis, which are developed by the sponsors or researchers but have not been used in other conditions. Now, generic measures of health-related quality of life, the PROs that measured this are SF36, PROMIS Global Health Scale, and PROMIS 29 Profile. 12 publications in AL amyloidosis have used SF36 Health Survey version 1 or 2. On the other hand, 4 manuscripts or published manuscripts for AL amyloidosis have used PROMIS Global Health Scale, and 2 published manuscripts have used PROMIS 29 Profile. condition-specific, specifically cancer-specific PROs that are used in AL amyloidosis in the published literature are FACT-G, EORTC QLQC30, and the NCCN distress thermometer, which are used in 1 to 2 publications. KCCQ12, which is a PRO developed for heart failure, has been used in 2 published manuscripts for AL amyloidosis, and HPRSS, which is a PRO that is used for hematologic conditions, is used in 1 published article. The single item assessments, PROs, that measure patients' functioning or disease severity at a global level has been used in handful of published articles, only ranging from 1 to 2. PROs that focus on mental health also, unfortunately, have been used only in 1 to 3 published manuscripts for AL amyloidosis. Specifically, Center for Epidemiological Study Depression Scale, CESD, has been used in 3 manuscripts for AL amyloidosis. PROs that assess single specific symptom-specific measures have been again used in only 1 to 2 published manuscripts. As stated earlier, certain PROs that have been used in AL amyloidosis are not easily categorized or were developed specifically for a research project. And researchers and sponsors have developed their own survey items to evaluate a variety of aspects of patient experience with AL amyloidosis. These topics have included symptoms, treatment tolerance, quality of life, and journey to diagnosis. And these were used in 3 published manuscripts for AL amyloidosis. After performing this strategic, formal, and thorough literature review, we then went to look at clinical trials used for AL amyloidosis, which are phase 3 randomized placebo-controlled clinical trials of drugs that also have had some FDA engagement. These trials are listed in this table over here. It is important to note that health-related quality of life endpoints were all secondary for all these trials. Furthermore, the patient population in these trials were heterogeneous, with some trials for newly diagnosed patients with AL amyloidosis and some trials for relapsed patients with AL amyloidosis. Moreover, the drugs that were used were also of different categories. Some trials were for drugs that are directed against plasma cell dyscrasia, and some trials were for amyloid busting agents or antifibril agents. Even to our surprise, the patient-reported outcome instrument that was used for these global multi-center phase 3 trials were all variable, including SF36, FACT-G, EQ5D, Amyloidosis Symptom Scale, EORTC QLQC30, and PROMIS Global Health. And to our even more surprise, that the measure or the score or the domain that was particularly reported for the particular instrument were all variable. For example, Pronto and Vital trials used physical component summary as the measure or the score of SF36, whereas Andromeda clinical trial used mental component summary of SF36 for reporting purposes. Now, the validation of PRO instruments in publications for AL amyloidosis is tabulated on this slide. I have focused on 5 PRO instruments that are listed in the top row: SF36, HPRSS, PROMIS-29, EORTC QLQC30, and EQ5D5L. The content validation and psychometric validation in patients with AL amyloidosis have been performed only for SF36. PROMIS-29 however, is undergoing content validation as well as psychometric validation for AL amyloidosis. Longitudinal analysis, meaning that changes in health-related quality of life before treatment and after treatment have been reported for SF36, HPRSS, PROMIS-29, and Global Health Scale of EORTC QLQC30 and Visual Analog Scale of EQ5D5L. Outcome predictions with respect to survival, risk of death or mortality, and organ responses have been reported in AL amyloidosis for SF36, HPRSS, and PROMIS-29. This study aimed to understand the symptomatic impact of AL amyloidosis from the patient's perspective. 4 data resources were included: a literature review, review of online patient blogs, expert clinician interviews, and patient interviews. This is the only conceptual model that has been published in AL amyloidosis. A conceptual model of disease depicts the impacts of the disease and treatment and the relationships among the impacts. It can be used to inform the selection of appropriate PRO measure for evaluating disease and treatment outcome. The conceptual model provides an overall picture of the symptoms associated with AL amyloidosis by organ involvement, treatment impacts, and the effects these have on emotional and physical well-being of the patient. A second conceptual model is being developed by Dr. D'Souza, who is a member of this working group. However, it has not yet been published. So in conclusion, the future plans for our working group include update of the conceptual framework, map concepts to existing instruments, and then prioritize concepts to measure for drug development with feedback and involvement of the organ-specific working groups and the patients, and finally, to make recommendations on existing tools and future directions. We hope to develop a set of recommendations on use of existing instruments and potential need to create a new instrument to cover gaps in concepts between the updated conceptual framework and in the existing instruments. And I will conclude here by thanking everyone, and we are open now for questions and answers and discussion.
Thank you so much, Vaishali. And I wonder if, just as people are beginning to put things in the Q&A, we would be able to have Paula Schmidt talk a little bit from the patient perspective on the sort of general quality of life questions. Paula.
Thank you, Sarah. As we've heard today several times, AL amyloidosis negatively impacts the quality of life of many patients, and the effects can range from mild to devastating. Treatment toxicities take a toll on all organs, not just those impacted by amyloid. Some patients are tethered to dialysis machines several days a week for hours at a time, and some suffer from fluid overload that can cause congestive heart failure. The balancing act of reducing that overload can cause orthostatic hypotension, which can then lead to fainting or falling. Debilitating, unexpected diarrhea can cause agoraphobia, and this fear of leaving the home can make patients unable or unwilling to go to see friends or even visit their doctor. Painful neuropathy, aching joints, and the overwhelming fatigue can often add to the mental stress and strain, putting even more hardship on the patient and their family. Despite each patient being different, the one overwhelming commonality is the devastation that this diagnosis causes. Most patients cling to the hope that a better treatment will be found and their lives can return to normal. Thank you.
Thank you very much indeed. Very much appreciate your sticking with this quite complex topic in the working group and giving these perspectives. Appreciate it.
You're welcome.
Thank you. Let's start the question and answers. And we have Dr. Havasi with a question. She asks, how cumbersome are the questions for patients and what is the compliance rate?
I can answer that a little bit in some studies. We actually have very good compliance across them. I think it also depends on how many measures there are included in a particular data collection time point, because we're never talking about one instrument being asked by itself at a time. I don't think anyone has a problem answering 10 questions or 30 questions. It's, you know, when there's a booklet of 100 questions, then you can get some questions or concerns about whether or not people are filling them out to the best of their ability every single time they're asked to. That said, we've conducted several observational studies where we've found very complete data, regardless of a 30 to 45 minute set of assessment batteries, and also conducted qualitative interviews with patients about their willingness to complete such instruments. And we've had overwhelmingly, and this goes across disease areas, a lot of support for wanting to have their voice heard and feeling that they would fill everything out.
I can also add to that an Andromeda clinical trial that I presented as a poster session at ASH 2020, the compliance rate was greater than 90% at all time points with respect to doing health-related quality of life surveys. And I think it also depends now, as Michelle mentioned, that SF-36 can take about 5 to 10 minutes for to complete the whole survey. PROMIS can take less than 5 minutes. Similarly, I think also EQ5D5L can also take about 5 minutes to complete. The recall period for each instrument is also quite different. So we didn't really mention that recall period for each instrument is either 4 weeks prior, 1 week prior, on the day off. So I think that also needs to be taken into consideration.
Next, we have Dr. Chakraborty. Raj, do you want to state your question?
That which PRO domain should be considered as an ideal domain to pick as a PRO endpoint in clinical trials of AL amyloidosis, because we have different domains being reported in different trials, and just to pre-specify and a domain. So which domain should be considered as an ideal? I think maybe physical functioning, but I wanted to see what you all thought.
I mean, certainly from literature review and from patient and as well as experts, what they say, it certainly seems like physical function, fatigue are very important domains. But again, as we heard from previous talks, depending on the organ involved, there might be other domains like we heard with GI symptoms or cardiomyopathy scales. So I think maybe physical function and fatigue might be important to many patients, and then depending on what organs are involved, perhaps that can be further customized for a given patient.
Okay, thank you.
I think also related to clinical trials, you have to consider the patient population for the trial and how fit for purpose it is based on what you expect the treatment mechanism of action and the responsiveness of the instrument compared to how quickly you expect a response. You really need to consider how fit for purpose that instrument is. So there really isn't one answer that goes across, but I completely agree with Dr. D'Souza that organ involvement plays a part in what you would pick. And certainly we've seen that some of the generic instruments in physical functioning, fatigue, and other domains might be useful to use across all studies, because then you would have a comparison, a comparison point that would go across all of them.
Thank you.
We have a question from Dr. Mauer. He asks, what did the working group feel about remote administration?
I think COVID has taught us a lot. We are doing this remotely as well. So, I think absolutely that can be done. I think, it has to be done, with good compliance, and somebody has to make sure that the research assistants, they are collecting everything. But I think it is possible. If they are coming in for treatment anyway, I think these surveys can be handed over to the patients, when they're coming in for treatment. And while they are waiting for treatment to be administered, these can be done.
Yeah, and I would say especially if the instruments are already being administered electronically, then there's not too much of a difference. And in fact, if a patient was completing forms on paper in an office and then has the opportunity to do them on a laptop or something else at home, it might even be more advantageous because automatic skips can be done, and it takes a little less time for them to read through everything and figure out what doesn't apply to them, and certain other time-saving advantages can be implemented using an electronic administration method.
Thank you, Michelle. We have a question from Dr. Buxbaum. He asks, are there any data relating validity of the various instruments across socioeconomic and different patient populations?
Maybe
Michelle,
Avery
do you want
Michelle
to
or Avery can answer that,
There's been a little bit of work in SF36 validation efforts, and the various demographic groups that were involved, there were no differences in any of the outcomes that we looked at, and any of the psychometric testing, et cetera. But I have to comment that because this is a rare condition, we're talking about quite small sample sizes. And when you're in a small sample size for an entire group, you also have very, very small sizes when it comes to some of those, and even organ involvement, the clinical characteristics as well. I mentioned demographics, but the same is to be said for clinical characteristics. Avery, I don't know if you wanted to add anything from your literature review.
No, I agree. Nothing came up as far as I remember in the AL specific literature stratifying by demographics, but certainly any stratification has been made difficult by some of the smaller sample sizes.
I guess the question I would ask in a broader sense, clearly Mayo Clinic population has a different socioeconomic distribution than the BU patient population. I wonder if you could draw any broad conclusions based on that kind of analysis.
I mean, I can talk from the PROMIS standpoint. So the PROMIS scale has been developed to be valid, and it's been validated across the entire and general US population, and then also has been validated in some other countries. So I think depending on the scale that we select, these scales have been tested across various different patient populations.
That's a good answer. I'm going to steal it for the SF36.
Indeed. Right, and not specifically for AL amyloidosis, but in other conditions and other diseases, and in general population, it has been, all these instruments have been probably validated for different socioeconomic thing. I think we need to stop because are there any other questions?
I think we need to move on to the last topic. So thank you, Dr. Sanchorawala, and thanks to everybody who asked questions and helped with this session.
Yes,
thank you for moderating.
Thanks indeed, and much appreciated. Great discussion there. So obviously a need to move forward with these tools, and the group will be putting it in the hands of some HRQOL specialists to develop new tools for AL. So thank you. Our